All right, we're going to go ahead and get started. Welcome. We are so glad that you've joined us today for a conversation about hormones with our amazing speakers, Meg Mizrachi with Congruency Therapy and Wellness, and Anya Wallace with Companion Health. I'm Ellen Thomas, and I will be your moderator for today's webinar. Kieran Dedeja Smith is also joining us from Companion Health, and the two of us will be watching the chat during the webinar. So if you have any issues, please reach out to us through the chat. Before I introduce Meg and Anya, I wanted to first just do a little housekeeping. First, a disclaimer. All information presented during this webinar should not be construed to be personal, formal medical advice, nor the formation of a doctor or other healthcare provider-client relationship. The content in this webinar is intended solely for educational and informational purposes and not for treatment purposes. We cannot offer specific medical advice over the internet. If you have any questions during the webinar, please drop those into the chat box on your screen. The education portion of this webinar, the conversation with Meg and Anya, is going to last approximately 30 to 45 minutes, and then we're going to have time for questions at the end, but feel free to drop the questions in as you think of them. Please do limit your questions to the content in this webinar. As I mentioned in the disclaimer, we cannot give specific medical advice, so please keep your questions general in nature. We are recording this webinar, and we will share a link with you in the next few days. You're free to rewatch and share with your friends that you think may benefit from this. Hopefully, all of you guys have had a chance. Oh, actually, let me share that poll with you. I just realized you haven't seen the poll yet. Let me share that with you now. All right, I'm launching a poll. You guys are welcome to fill that out in the beginning of this webinar as you would like. All the responses to this are anonymous. I'll close it in a little bit as we get started, and then Anya and Meg are going to share those anonymous responses with you later on in this presentation. All right, so I'd like to introduce our guest. First up is Meg Mizrachi, a therapist with Congruency Therapy and Wellness. Meg received her doctorate in physical therapy and is a board-certified orthopedic clinical specialist. Prior to PT school, Meg earned a Bachelor of Fine Arts in Dance and worked as a professional dancer in New York City and abroad. Also an accomplished runner, Meg has run the New York City Marathon and has a passion for fitness and wellness and in helping her clients move and feel their best. Next up is Anya Wallace, a provider at Companion Health, a primary care functional medicine group. Anya received a Bachelor's of Science in Exercise Science from the University of South Carolina, followed by her Master's as a Physician Associate from Wingate University. She then furthered her education in functional medicine with a focus in endocrinology through A4M. Anya is also a Black Belt in Krav Maga, as well as a Purple Belt in Brazilian Jiu-Jitsu. Anya has a passion for all things women's health, hormonal balance and management, gut health, and ADHD. On a personal note, I just have to say I am lucky enough to be a client of both Meg and Anya's. I can truly tell you that both of them are rock stars. Their combination has been amazing and has allowed me to feel the best I have in years. I know you're going to love learning more about women's health and wellness from these passionate women. So without further ado, I would like to hand it over to Meg and Anya.
Thank you so much, Ellen.
Thanks, Ellen.
So I know that I have been interested in this topic since going on hormones in the form of birth control at the age of 12. What has made you so passionate about hormones?
So starting into endocrinology, it really kind of actually spawned from my dad. My dad has a type of adrenal disorder and he also has a thyroid disorder. And I saw the way he was never really ever explained what was going on with him. So I dove deep into endocrinology and really sought to learn as much as I could, share it with him. And then in terms of patient relationship, I wanted them to have that same experience where they actually really understood what was happening. And then I started seeing a lot more women and I saw this big discrepancy in women's health. And I just kind of started filling that void and it became kind of my thing. So,
awesome.
Yeah.
So can you define for us what hormones are, how they interact with each other, and which ones we'll be really focusing on today?
Yeah. So at its core, hormones are just chemical messengers. So this here is my lovely brain drawing. I do this with all of my new assessments. There's a lot going on here and I'm not an artist. That's my little thing. Sorry. But so I draw this whole thing out basically to show how all these different hormones are interacting with each other. The main ones we're going to be talking about today is kind of this pathway here, looking at FSH and LH, and we'll explain kind of what these are a little bit more later on. Estrogens, progesterone, a little bit of this DHEA, cortisol, and testosterone. But the gist of this is basically talking about how it's not just one gland working in isolation. It is all of these glands and all of these hormones and all these different things consistently interacting with each other to produce a certain effect. So, but essentially hormones, they just take one message from an organ, a tissue, a gland, and they send it to another in order to carry out a function. So,
And with the sex hormones, can you also elaborate on how those might change over time?
yeah. So specifically looking at kind of in women, and so on this graph, you've got two things. This pink dotted line is your estradiol. It's one of your estrogens. It's kind of one of the main functioning estrogens. And then you've got progesterone, which is this teal line here. So this is essentially looking at everything from puberty, where they start to get a little haywire, all the way through these kind of reproductive years. This is what we call a steady state here, where it's nice and even as you go through. And then you hit perimenopause and you see they start to get a little crazy. This is where, if you've heard the term estrogen dominance, this is kind of the concept behind it. It's essentially this estradiol is so much higher than the progesterone. You see this big change and this big differential between them. And this is where you're getting a lot of some of those perimenopausal symptoms. And that can just change based on age. So age-wise of perimenopause is simply, you're not ovulating as much, so you're not getting this hormonal response that you need. And that can start as early as 35 all the way up to ages 45, and that's plus or minus a few years either way. The next step of this is going to be menopause. And so menopause is truly just 12 months without a cycle. And this is usually diagnosed retroactively, meaning you go 12 months without having a period. You start to see big hormonal changes with that. And so you can see here, this estrogen is way up here and progesterone's way down here. This can vary person to person though.
How might a woman know if she's entering perimenopause?
Yeah, so this is looking at some of those signs and symptoms that we put in that poll. Ellen, can you help me out with that?
Maybe let's see.
Yeah. All right. So you can see kind of how they're all over the place. You can get these are most of the biggest ones that I tend to see from people. Hot flashes is kind of the classic one that you'll see kind of in even in TV and all that. People talk about hot flashes, but fatigue, trouble sleeping, changes in weight. This is most of the time weight gain, but you can see weight loss as well. Hair, skin, nails, brain fog, irritability is a big one. And then changes in libido are another big one as well.
And is there a way that you test for that you can determine where they are in terms of their hormone levels?
Yeah, for sure. So there's a couple of different things we can look at. In the blood work, we will sometimes look at that FSH and LH. Those are, go back so you can see. That's these looking here. These are those hormones that are coming from the brain to tell the ovaries to do what they need to do. Those will be higher when you actually reach menopause because the brain is trying to pump out more to get the ovaries to ovulate and then therefore release estrogen and progesterone. We also do saliva testing here. And so that saliva testing lets us look at, some of these other hormones, specifically looking at this estradiol, the progesterone, the DHEA, and the testosterone.
Gotcha.
Yeah.
I know for pelvic floor physical therapy, typically we hear about these complaints, but we don't see someone until that has kind of snowballed or spiraled into a pelvic floor pain or pelvic floor dysfunction. Particularly, it wasn't on the poll, but there are tend to be tissue changes due to an estrogen deficiency, whether it be thinning or dryness that then can create pain with sex or even bleeding with sex. And that can sometimes send someone to pelvic floor therapy, but it's not until I think that pain starts to create an anticipation of pain, which leads to muscle guarding, which over time can produce just overall tension and muscle spasm.
Yeah.
That makes it really difficult.
Yeah.
And that obviously requires treatment at that point. going in one step further is when that tension, that chronic tension, then develops into pelvic floor dysfunction.
Yeah.
And I think it warrants talking about here because there are a number of different kinds of incontinence, but particularly in this subset of women, I think we see either tightness or tension that causes incontinence. And that might be from this pelvic pain scenario, but oftentimes it's just due to stress and anxiety.
Yeah.
And then we can also have the muscle weakness, whether it's laxity, whether it is just due to, muscle loss over time, right?
Yeah.
Sarcopenia. So as we age, if you don't use it, you lose it. And it also warrants mentioning that because those two scenarios are so different, Kegels are not the recipe to improve both situations, right? If you have a tight pelvic floor, it's not appropriate to then do Kegels and make it even tighter.
Yeah.
So being able to identify which type of pelvic floor is then creating that incontinence, I think is really important.
Yeah. And then on the flip side of that, with hormones, Kegels aren't going to fix, vaginal lining thinning or anything like that. With the vaginal dryness, for us, when we're looking at hormones, that's primarily driven by this other estrogen here, this estriol. And it doesn't necessarily have to be, you don't have to be sitting there going, no, I'm good with all that. It could be you're getting more UTIs than you used to. It could be, I know you had told me a story about the ladies in your neighborhood and like jumping was not a thing because of, there was some urinary incontinence there. Sometimes the muscle's involved with it, but that muscle issue is sometimes driven by the lack of that hormone being present.
Yeah. And I think it's also, incontinence becomes something, especially post-pregnancy, that is considered normal when in fact it's not, common, though it is very common post-pregnancy and also later on in life. It's not normal and it's absolutely treatable. And I think that's a big understanding that people need to know.
Yeah, absolutely. And looking at some other things that hormones are involved with, it's not just the pelvic floor. It's not just breast tissue. Hormones are involved with so much else, particularly whenever we're talking about bone health. And so osteoporosis and osteopenia is a big concern a lot of times for women who are menopausal. And so, they think, oh, I've got to take my vitamin C and my calcium and I'll be good to go. And it's not necessarily the case. Bone density is driven a lot by some of these hormones. Estradiol especially has some big functions in terms of maintaining bone density. That testosterone and DHEA over here on this side, these are androgenic hormones. So they are there to help build up bone. And then on the flip side of that, you've got cortisol, cortisol being your big stress hormone, that will actually break down bone. So, as we talk more about some of the lifestyle things coming up, stress is a big part of that. And so it's not just your vitamin C or your vitamin D and your calcium, and there's so much more to bone density.
Yeah, I'd say one of my pet peeves is when I get a patient who's had a total hysterectomy, but was never educated on what it would mean to be living in the absence of some of those hormones to their bone density, and then seeing people down the line with, fractures or delayed healing that might otherwise not have occurred. But there are some really compelling ways, I think, to improve bone density if you are somebody who's already struggling with osteopenia or osteoporosis. Right. So I know in my research, I've really gravitated toward the articles from Dr. Lauren Fishman out of Columbia talking about yoga. I think what makes yoga so great is that it also enhances postural stability and support from the muscles surrounding the joints in an effort to really protect them. But of course, there's also information like you were saying about resistance training.
Yeah, so I talk a lot with clients, especially women, about strength training. And unfortunately, now we're starting to kind of shift more where women are doing more resistance training. But there are so many good benefits just from doing resistance training. And there's so many studies that are starting to come out about this now. But just on, there's a hormonal side, and then there's what we call the mechanical response side. And the hormonal side, just 15 to 20 minutes of resistance training to a certain degree, you see rises in testosterone and growth hormone. You see insulin sensitivity improve. So that in itself is stimulating some of these improvements and some of these hormones here, just from the actual process, like the muscles having to undergo. And then on the mechanical side, by doing some of these resistance training and putting tension on the bone and tension on these muscles, the body's going to adapt. And so it's going to increase protein synthesis to make the muscle bigger. And then you're going to see bone rebuilding happening just because of that.
Right.
So it's not just about go out and run or swim or whatever. It is about actually utilizing some of these actual hormonal responses that happen.
And obviously we're both fitness addicts, so we're biased towards exercise.
Love it.
But I know you also counsel women a lot on the different lifestyle changes that would enhance their ability to cope with symptoms that they might be having. Can you go more into what those recommendations might be?
So, being a functional medicine practice, we talk a lot about, I call it all the life stuff. It's all of the things that we do throughout the day that are contributing to all of the medical stuff. So stress management is a huge one. Cortisol, we need it to survive, but at the same time, too much of a good thing is a bad thing. So as I mentioned earlier, cortisol can break tissue down. So by trying to manage some of the stress, we can decrease the amount of cortisol that's getting pumped out and stop some of that from breaking down. Sleep is another huge thing. Sleep is like the secret superpower. By getting adequate sleep and getting into these proper sleep cycles, we are actually able to recover from the day, whether that be mentally or physically. And it's, the time that your endocrine system does everything. Your growth hormone goes up in the middle of the night, and then from there on out, follows the rest of the hormone cascade. Nutrition is a big one. And it's not just about, being plant-based or gluten-free or dairy-free or whatever it is. It depends on the individual. So, we get all into gut health and everything, but nutrition and the nutrients and the protein and fats and carbs and everything like that, your body needs all of that to make hormones. I mean, cortisol is the base of all hormones. If you don't have enough cortisol, you're not going to make what you need. And then alcohol is the other big one. Primarily, that's kind of leading into liver function. Your liver is very important for producing, metabolizing cholesterol, and then therefore making the hormones. But alcohol is a toxin to the body. Even if it's delicious, it is a toxin. And so your liver is going to prioritize detoxing and breaking down that toxin before, making hormones.
Yeah.
So.
And just on the nutrition side, I want to take a step back to that part of your slide that talks about puberty, because that's also where we get into, at least nowadays with the rise of sports specialization, missed periods. And I think those are just as important to identify maybe risks of hormone imbalance and bone loss that we see in what's called female athlete triad, right? So that's getting inadequate nutrition for someone's needs, whether it comes to just doing so much exercise and not being able to fulfill, what they need to perform. And then in addition, all of their normal body processes. And then, that can be a really slippery slope there.
Oh yeah. And, I've seen, I see several teenage girls that, whether they are athletes or not, they think that, period abnormalities or whatever it may be, they're just like, oh, well, I'll just go on birth control, which that gets me down a whole other rabbit hole on that. But, that's not always the answer. Sometimes it's, are you getting adequate nutrition, especially protein?
It can be an important sign to something else that's going on.
Yeah, for sure. Yep.
So on the flip side of that, right? Because we can talk about what makes hormones great and protective and preventative all day, but there's still so much fear surrounding it, particularly as it pertains to things like cardiovascular risks and cancer. So what do you make of all that?
So to kind of preface this next part, whenever we're talking about study design or research being done, pretty much every single study that is ever done has a goal in mind. And so we're going to talk about the Women's Health Initiative that was actually began in 1993, but was stopped early in 2002 because of these results that they were seeing. However, they went into this study with the intention of finding out how bad can it get. So it wasn't like, oh, hey, let's make women healthier, which in theory was what they were trying to do, but it wasn't actually the case. It was, okay, well, let's put these women on these hormones and let's see how bad their cardiovascular risk is, how bad their breast cancer risk is. Do they get breast cancer? Do they have a heart attack? So that in itself was already kind of lending a little bit of bias to the study. But long story short with that, what they did is they created the study, and they took these women who were aged anywhere from 50 to 79, and they put them on certain hormone protocols. And those hormone protocols were either an estrogen alone or an estrogen and a progestin. Now, the big thing with this study is they were synthetic hormones. So the estrogen that they were using was actually something called Premarin, which, in case those of you that don't know, Premarin is made from pregnant horse urine. So just fun fact. And then the progestin, which progestin is not actually progesterone. It is a synthetic version of it. And there's so much data out there about how progestin is actually terrible for you, especially when you're taking these hormones by mouth, which these women were. And so they took this, there was only one dose for them. They gave them either this estrogen or estrogen progestin, and then they saw how bad their risk could get. And so they stopped it early. They made this big hoopla about it. And they're like, hey, it causes cancer, it causes cardiovascular risk. Women's hormones are terrible. And so it created this downfall of all these women coming off of hormones and having all these now adverse effects, which, fun fact, the study was retracted about 2013, 2014. And they said, oh, hey, just kidding. Like, all of these women that come off of hormones now are having now worse outcomes because of it. So unfortunately, like, as we've seen kind of in the last couple of years in terms of medical things coming out, if you make a big enough deal about it beginning, people are going to believe it. So like, oh, it's in the news, but then retractions aren't paid attention to. That doesn't get as much because nobody wants to admit they messed up.
And I think you had a graph, right, about that.
Yes.
Yeah, I wanted to talk about that for a second because I found that really interesting.
Yeah. So this graph, this purple line is your estradiol and this green line is your progesterone. These two things here are essentially showing what the previous graph was. The big thing I want to point out in this graph is this red line. So as you can see, as this progesterone and estradiol are dropping, you actually see your risk of breast cancer go up. And this is not on hormones. This is the natural decline of hormones that happens. That is because of the way hormone metabolism is shifting as we age. And the other thing is there's one of your estrogens is called estrone. That shoots way up as you get into menopause. It's the primary estrogen of menopause, and that in itself carries a risk of cardiovascular disease and breast cancer risk. So it's actually the opposite of what is kind of widely known out there. So we're here to try to fix that.
So what you're saying is breast cancer risk increases naturally as our hormone levels decrease.
Yeah.
So it wasn't necessarily a result of that specific study.
Yeah. And the other thing too is I talk a lot about this thing called a 10-year window. And that 10-year window is essentially the first 10 years after menopause. And it's important because that is kind of the optimal time frame to start bioidentical hormone replacement. And the reason being is trying to decrease some of these risks. And so it's not just breast cancer risk. Estradiol is very important for cardiovascular disease. It helps decrease the deposition of plaques in the artery wall. It's very important for memory. There's something called acetylcholine in the brain that has a lot to do with memories. And as estrogen increases in the brain, so does acetylcholine, and it helps with all of that. It's also very important for Alzheimer's disease. Same thing with Alzheimer's, or with estradiol increasing in the brain, you see less plaques being deposited in the brain and therefore less signs and symptoms or prevalence of Alzheimer's.
Now you mentioned in the study, and you kept saying that these drugs were synthetic that they used. So what do we use now and how do those differ?
Yeah, unfortunately, these synthetic hormones are still being used quite a bit. But I'll get a little bit more into that later. But synthetic simply means it is chemically different than what your body makes. And the danger with synthetic is your liver has to metabolize that and break it down. And so in the process of doing that, it's creating these byproducts that cause issues in themselves. The primary thing being it increases your clotting risk. So birth control pills, while even though they're given out like candy, there is a clotting risk involved with them. Like I've seen teenage girls throw blood clots and have heart attacks and have strokes just from being on birth control pills. And then we do what's called bioidentical hormones. And so bioidentical or body identical simply means that it is chemically, structurally the same as what your body would produce. So it's safer because your liver isn't having to break these down. And the other thing we do with it is we dose it differently. And so a lot of the synthetics are, you take it in by mouth. So it has to go through the liver versus we do topical for estrogens and our testosterone. And then progesterone is a little bit different. So you can do that one by mouth.
Now, you mentioned all three, right? In the studies, one was just estrogen, one was estrogen and progesterone. But I know a lot of my clients at least have mentioned taking testosterone.
Yeah.
Well, why is it so important to make sure that you're having all of these in balance?
Yeah. So testosterone is just as important in women. Testosterone is actually, when you look at it, most of the time it's actually higher than estrogen and progesterone in women. It's just the levels are different on blood work, and so it looks weird. But testosterone is very important for not just sex drive, which is what most time people think of, but again, that muscle building, that bone density. It is also can be a precursor to your estradiol. So there are functions for testosterone outside of just having a sex drive.
Mm-hmm.
So
yeah, I've definitely seen or suspected with some of my clients who are deficient in testosterone that they're really having a hard time creating the gains that they want to, when our specific goal is to increase strength.
Yeah.
And similarly, with a population of clients who have connective tissue disorders or hypermobility, some of them are put on progesterone only birth control to manage maybe painful menstrual periods.
Yep.
And then they have a dramatic increase in laxity on account of only having progesterone.
Yeah.
So I think it's prudent to make sure that you are balancing out those hormones.
I mean, there's a time and a place, for birth control pills or for an IUD or something like that. We're not saying that it's evil. It's just that, it's not always the quick, easy answer isn't always the correct answer, even if it's convenient.
Mm-hmm.
So, yeah.
Anything else you wanted to mention before we turn it over for questions?
I would just say kind of overall, everything in the body has a balance. And so, looking like the muscle side, people know like, oh, there's a bicep and a tricep and a hamstring and a quad. But it's the same thing in the body with hormones. You have your estrogen and progesterone, you need that balance. When they get out of whack, that's when you start to get some of those signs and symptoms and you don't feel great and you're not sleeping well because you don't have progesterone. But these hormones are also feeding back with neurotransmitters. And so you've got estrogen that feeds back with norepinephrine and epinephrine, and which are a little more stimulatory. And then you've got progesterone that's feeding back with GABA, which is a calming neurotransmitter. And so this gets into, you can get into like PMS and PMDD and some of these other things, but you can get way into the weeds in all of these things, but ultimately it's individualized. It's not just the hormones, your gut health is important. It depends on the person. It depends on what was your birth control history like, depends on your family history. It's just, it's not one size fits all.
Yeah.
For sure.
So I think we do want to have a lot of time to answer questions. So I'll turn it over to Ellen to see if there's anything out there people want to know.
Yeah, awesome. Thank you guys so much. I learn something every time I hear you guys speak, even though I've heard you talk about hormones a lot. I always learn something. Thank you so much. That was a great conversation. We did have a few questions. One of them was, you talked about a 10-year window. What if I'm already outside of that 10-year window? Do I still need to worry about it, or do you sort of age out of when it's an issue or you can treat it?
Yeah. So long story short, any hormone is better than no hormone, with a caveat. There's never 100% in medicine, but even if you're outside of that 10-year window, by getting even on a little bit of hormones, you're working to decrease further risk. Whenever we do hormone replacement, we're not trying to make you 20 again. Like, that's just not healthy. We're just trying to get enough so that the tissues can be healthier and function the way they are. Aging happens for multiple reasons, but one of those primary reasons being hormones are dropping down. And so sarcopenia is just a fancy word for the body breaking down due to aging. So all of these disease risks increase as you age because we have this loss of hormones. So even if you're outside of the 10-year window, looking at your levels, assessing kind of risk versus benefit, that's always very important. And again, it's very individualized. I still think it's important to be on something.
Thank you. Another question somebody asked, should I worry that my teenage daughter is on birth control?
It depends, honestly. Like I said earlier, there's a time and a place for it. So if it's something that, your teenage daughter is sexually active and she can't or shouldn't or whatever get pregnant, okay, like birth control is important. My big thing whenever I'm talking to young adults and parents about birth control is, it's a fix in terms of not getting pregnant, but it's not a long-term solution necessarily. Just understanding the risks. Like, I know I was never really educated on, hey, like there's a strong risk of clotting. Like, you can have a heart attack, you can have a stroke, you can have all these issues. So I find it very important. And personally to me, I spend a lot of time educating on it. So worry, maybe not. It depends on the reasoning for it.
I think it's also about the trust that you have in your OBGYN, because there's such an array of options for how birth control, which one it is, how it's delivered, and your response or side effects to those birth controls. I know, that I've been on so many different varieties of birth control, and you have a totally different interaction with each one. So I think it also depends on how is she responding to it, and is she feeling really great, because then you might be in a good position. But if there's any question mark about side effects or just feeling off while on that medication, and then I think it always behooves a question to your provider.
Yeah. And I mean, there's a reason for those side effects. I mean, side effects happen with medications because they're altering a normal function in the body. So just keep that in mind.
Awesome. Thank you. I had another question. For those of us who are outside of Charlotte, how do we find a comparable physicians group that focuses on women's hormones? Are there key questions that we should ask when we're calling around, or to find the right provider? Are there certain things we can ask our OB?
Yeah. So the big overall, I tell women this all the time, like outside of hormones with anything, I tell people ask questions. And if whichever provider you're talking to seems annoyed or isn't willing to take the time to answer those questions, may not be the right provider. It may take doing consults at multiple places or finding a different provider. One of the big things I'm very passionate about is getting women to feel a little bit more empowered to take control of their health, and to ask questions, and to not just be like, oh, I got to power through and like, it is what it is. Like, this is just part of being a woman. Like, you don't have to feel miserable. Anyway, so asking questions, I would just say, whatever questions you have about the way you're feeling, ask them, and ask them, like, there's a difference between normal and common, like Meg was saying earlier. Even though it's common to have hot flashes, it's common to be exhausted and all of that, and women just kind of suck it up and deal with it. It's not normal. Like, it shouldn't have to feel that way. So asking about hormones, whether it's blood work or there's salivary testing, that's just the way we do things here. There are other functional medicine practices out there. That said, we do virtual care where we've got people kind of all over. So there's options with that as well. But
I think there's nothing more important than having one, like you said, feeling empowered to take control of your health. This day and age, you need to be your own advocate. But there's nothing more important than really trusting the provider that you have, because I get so many people really dissatisfied with the care that they receive, whether they're feeling like their doctor is dismissive, or just not either paying attention or listening to their concerns. Mm-hmm. And that is absolutely a sign that you should seek someone who is willing to go that extra mile for you.
Yeah. I've had women tell me that, and unfortunately, I feel like this is a little more prevalent with male providers. But I've had women tell me that, they'll come in and they'll talk about how they're irritable or they're not sleeping well. and they just write them an antidepressant and they write them a sleep medication. And they're like, okay, here you go. Like, welcome to menopause. And like, they don't even bother to explain what's happening or other options. And there's just a lack of, honestly, compassion when it comes to it. So yeah, I mean, if you weren't satisfied with where you're going or the answer you're getting, go somewhere else. Yeah, find somebody else.
And Anya, I know you've done a lot of training through A4M. Does A4M or IFM, can you talk a little bit about that? Do they have resources where people can go and search for providers that are maybe certified like you are?
So I believe they do. I'm not sure about IFM. I'm pretty sure A4M does have a search functionality where you can see, but also too, Googling gets kind of dangerous because there's a lot of people that use kind of this catchphrase of functional and concierge and whatever. So there may have to be a little bit more research on that side of it, but I believe A4M you can search. But there's tons of resources out there, like ZRT, the company we use for saliva testing. They have tons of little like webinar videos and little papers and resources that anybody can go on and look into it. And I think even with ZRT, you can search providers to see who does that. So.
Okay, another question. Can you explain why progesterone is commonly given after having birth?
Yes. It has to do with progesterone balance and estrogen being way out of whack. And you may be able to talk a little bit on this in terms of pelvic floor, but it could depend. Some of it may have to do with breastfeeding. Some of it may have to do with repair of tissues. It's hard to say for sure, and I give a blanket statement on that. But my best guesses would be probably having to do with breastfeeding, repair of tissues post-birth. C-section is a little bit different than vaginal. That's what I would say. But it's hard to say for sure on that one.
Awesome. Somebody's asking if you have taken birth control for a long period of time, like 20 plus years. I know you mentioned a lot of people's OBGYNs have told them just to stay on birth control through menopause. If you've taken it for a really long time, can it contribute to positive coronary artery calcium score or anything?
Absolutely. Yep, 100%. Birth control pills, especially the combination pills, contain progestin or a version of it. Most of them do, which there's multiple studies and showing that it contributes to cardiovascular disease. Plus, the other thing too is that birth control pills are giving your body fake hormone. And so, but it's similar enough to trick your brain to say that you have enough. So it shuts off that FSH and LH coming out of the brain so you don't ovulate. So you weren't making the actual hormone that you need. And so by not having the estradiol that you need, you are in itself, just from that perspective of it, contributing to cardiovascular disease.
That's interesting. Okay, another question says, I've tried several multivitamins to help supplement my nutrition, but still experience anxiety after taking them. I've been told it might be a sensitivity to B vitamins, but wondering if that has anything to do with perimenopause or if there's any approaches you would take.
Short answer is yes. Multivitamins are great, but they're not the fix for all of it. There's constantly multiple reactions happening in the body. A lot of times those multivitamins are just a part of that reaction. Like if you don't have the hormone or you don't have enough of the neurotransmitter or whatever it is, then it's great if you have B6, but you don't have everything else that you need for it. The other things, you see an increase in irritability and anxiety perimenopausal timeframe because your progesterone tanks. And as I mentioned earlier, progesterone feeds back with GABA, which is a calming neurotransmitter. And so there's multiple aspects to this. So multivitamins are great, but it's not gonna fix everything. And in terms of sensitivity to B vitamins, I don't know. You need B vitamins for a lot of things. Like I said, specifically to do with some of these hormones and these neurotransmitter reactions that happen in the body.
We have time, I think, for a few more questions. You talked about alcohol. Does that mean we can't drink at all when we are going into perimenopause?
Nah, I'm not going to take that from you. It's just a disclaimer that, even though, old fashions and wine are delicious and all of that. It is a toxin. Like it just is. We can't make that go away. It's not that you can't, it's just understanding that this is the effect that you have on your body. Like I talk about this whenever I'm talking about gluten-free and dairy-free and some of these nutrition changes we talk about a lot, is that it's not that you can't, it's more understanding that this is the effect it's having on your body. It's creating inflammation. It's creating more work for your liver. So you're not going to get kind of the optimal ranges or the optimal health that we talk so much about.
Awesome. Thank you. One more question. Do you have any tips for dealing with weight gain as people enter perimenopause?
Get your hormones checked. But I mean, you know, a common thing that I see is women will just restrict their food more and then they'll work out more, which is just making your cortisol increase, which is stimulating this response in your body to hold on to more fat because, you know, even though our bodies and brains are fascinating, ultimately, like our body and brain still thinks we're in hunter-gatherer times and it's like it's in a stressful time period. So it's just going to hold on to everything because it thinks we're going into a famine state. So get your hormones checked. Like it's not always exercise more, eat less. Sometimes it's eating more and exercising less.
I have a question on you.
Yeah.
What interaction do you see between hormones and caffeine?
So caffeine plays more on the role of like cortisol and epinephrine and norepinephrine and some of these other, what are called catecholamines. It's a stimulant. And so it can essentially cause this increase that you see in cortisol and epinephrine and all of that. But, you know, there are certain people that they don't tolerate caffeine. That gets a little bit more into, again, the individualized approach. But also too, you know, I talk with people about caffeine in the mornings. And so even though you're circadian rhythm, there's cortisol and there's melatonin, like it's not just those things. There's something else called adenosine that is going on where sometimes when you first wake up, your body's still clearing that out. And so if I have to have my coffee when I first wake up in the morning, that's great. You're going to feel a little bit better. But what happens is as that caffeine, your body finishes metabolizing it, you're going to get a big afternoon crash because your adenosine is still hanging out here. Because when that caffeine comes in, the body is like, oh, okay, we don't need to keep breaking down adenosine. And then once the caffeine goes away, it shifts back. So caffeine plays a role. It's not an evil necessarily. Some people feel better with it. Some people don't. Again, too much of a good thing can be a bad thing. And then you can get into caffeine in the evenings and how it's affecting your sleep and blood pressure and heart rate and all these other things. But yeah.
Question, Meg, I like that. Can you speak on spotting between menstruation as it relates to perimenopause?
So spotting can be a couple of things. Sometimes it's just the change in the uterine lining, whether that be because some of those tissues are breaking down and there's actually like tissue frailty. Sometimes it is progesterone being all out of whack. So you have a period because of progesterone withdrawal. So as progesterone drops, that signals your uterine lining to essentially shed. And so if your progesterone is going a little bit up and then a little bit down, your body's like, oh, it's low. Okay, it's time for us to spot. So it kind of depends. There's kind of a few causes to it. Spotting isn't necessarily a period. It's just the uterine lining shedding little baby amounts.
Thank you. All right, I think this is our last question. You talked a little bit about in your brain drawing the thyroid. Is it possible for the thyroid and menopause to get confused, for people to think they have a thyroid issue when in fact they may be in perimenopause? Can you talk a little bit to that?
Absolutely. So this is the whole reason that I do the brain drawing, because I talk about how all of these systems can interact and kind of confuse one another. So thyroid has a lot to do with metabolism and multiple systems of the body. And so you can have a thyroid disorder that affects menstruation. You can also have issues with cortisol. When cortisol gets a little out of whack, it will suppress this TSH coming out, which is telling the thyroid to produce hormone. I call it fake hypothyroidism. It has to do with, even though you're having signs and symptoms of a thyroid disorder, it's really just your cortisol is messed up. So the whole point of kind of all of this is it's not just checking an FSH and LH and be like, yep or no. You have to look at, okay, what is the thyroid doing? What are their adrenal glands doing? And then take that kind of whole system approach to see, okay, it's not just going to be, here's some hormones and send you on your way. It's going to be, okay, is it something where there's an issue in the gut or there's an issue with the adrenal glands and we need to get the adrenal glands to calm down whichever way we do that. And that's going to calm the thyroid gland. Or is it that, there is truly a thyroid issue, like autoimmune disorders with the thyroid can cause some further issues because autoimmune is an inflammatory disorder, which can lead to other issues in the other systems as well.
It really is one big complicated mess, right?
And there's, so many arrows.
I think that's it for questions. I didn't know, could you guys give us just a few? I know we talked about a lot of things, a lot of questions. Can you give us just a few of your kind of key takeaways leaving this webinar that we really should keep in mind?
I think just based off of what Anya just mentioned about these really complex interactions is that I know, at least with my group of friends, it's very easy to just go on Instagram or TikTok or the internet and receive information from people about hormones and have it prescribed or take advice that may not necessarily be the best option, right? It may not be taking into account all of your personal system's reactions. So being very cautious about where you get your education, what resources you're using, and running it by a provider before you go about changing massively, what you're taking into your body.
Yeah. I feel like TikTok and Instagram have become the new WebMD with all the influencers, but it's not necessarily a bad thing to look at those things and research those things and educate yourselves, but don't take that at like what it's telling you at face value to be necessarily fact. Like bring it to your provider, do more research, and then if your provider doesn't just dismisses you, then okay, do research on your own, unfortunately, or find a different provider. But again, like individualized approach is a big thing. Not every single woman is the same. Like if you look at that poll, there's just multiple different signs and symptoms. Sometimes people don't have anything. If something's off, like your body, if something doesn't feel right, like ask about it. Do look more into it. Like you don't have to feel crappy. You don't have to just be like, this is how it is now.
Mm-hmm. It feels like that, the social media is filling a void, but it's really comes out of us really not talking enough to one another as women, and to our providers about something that really is affecting our quality of life on a huge scale. So just having this be one little piece of raising awareness around it and being more vocal about it will show that this is something common amongst us all and needs to be addressed.
I love how you said that. I agree. I think we all, as women, it's a little bit of a taboo subject. We get told, especially by sometimes our OBGYNs that may mean for the best, but we get kind of told that, suck it up, like you said at the beginning. So I love that we're having this conversation. I hope we have more of them.
I still have a lot of women that come to me that are like ashamed to talk about any of this, and they're just like, oh well, we didn't really like talk about it, and like they'll preface telling me something that's going on and they're like, oh, this is a little disgusting, like they're telling me about their period. I'm like, it's not disgusting. Like, yes, I'm a medical writer, but like that, like every single woman has that, like, but like they don't talk about it, and it's like this thing of like, oh well, it just kind of is. And I don't think it should be that way. I think women shouldn't be secretly judging or whatever, and understanding that everybody kind of has their own thing, and it's okay to like have these discussions and learn more and want to learn more. It doesn't mean there's something wrong or broken or whatever.
Awesome. Well, thank you guys so much. We got a couple questions if we were going to be sharing this presentation. We will be. In a few days, we will have a recording that will come out to you. You're welcome to share the link with friends. You're welcome to rewatch it as many times as you would like to. We're also going to drop the websites for companion health and congruency therapy and wellness into the chat box. If you'll give me just a second, I'll drop those in. Also, a quick survey is going to pop up on your screen when we end the webinar. So please take a moment to answer the questions to help us improve our education events. And we wanted to say thank you again so much for joining us today. We wish you all the luck in the future for a healthy and happy life. Thanks so much for joining us. Bye.